care units in country in 1986. Shirish Prayag started annual workshop in mechanical ventilation in India 1998, a historical milestone for the oldest mechanical ventilation course in the world. First of its kind, spanning 25 glorious academic years through two pandemics, having 3,000 plus doctors and still running successfully for last 25 years. An excellent inspiration clinician, teacher, father figure, and above all, excellent group leader. Prayag sir, stage is yours.
Thank you, Dr. Joshi, and thank you everyone for this immense honor of asking me to give this commemoration lecture. This lecture is basically as a contribution to the 25 years of mechanical ventilation workshop. And this is going to be more a description of our journey over the last 25 years and some thoughts on the future of both mechanical ventilation as well as the field of critical care medicine. As I said, this is a more of commemoration lecture, more a lecture on the memories of last 25 years as they start flooding in on a day like this, and some thoughts about the future of mechanical ventilation and critical care, the journal with the philosophy coming in with grey hair. So that's the way I'm going to go through this afternoon. So it's been a remarkable journey of 25 years of mechanical ventilation, and as I look back, it sometimes sounds unbelievable, sometimes it sounds as if it can't be 25 years, but it stays very well edged. It started way back when I was training in internal medicine for my post-graduation. The medical colleges in India at that time looked like this, and we were essentially, while doing our residency, saving lives primarily through dedication, despite very basic infrastructure and equipment, and trying to overcome that with some help from science, but mostly from a lot of common sense. So from that perspective, we were treating a large number of our patients. My first encounter with artificial ventilation was during those trainee days on a patient of tetanus. That time tetanus was very common, and we used to relax these patients and give sedation and many times muscle relaxation, and therefore they needed artificial ventilation. So this gentleman underwent a tracheostomy, and there were no mechanical ventilators in the medical college that I was studying in, and therefore we procured an ambu bag from the anesthesia department and asked the relatives to do a rotation of period, taught them how to ambu bag, and they were ambuing this patient for a significant period of time. Over 7 days, gradually as the tetanus settled down, this man came off these jugaad kind of artificial ventilation that we had done. And that stimulated my interest in the field of mechanical ventilation. When I started going through the literature, I found that the Copenhagen polio epidemic had been one of the significant contributors to the evolution of the field of mechanical ventilation. And as it turned out, this paper, which was from Bjorn Ibsen's observations, came out at a time when I was just born. So perhaps it was destiny that this paper and my birth coincided and made me go into the field of mechanical ventilation. Over a period of time after completing my post-graduation, I started getting interest in the field of critical care, primarily because of the complex issues and the fascination of the interaction between various organ systems and their interrelationships. So that fascinated me, and then I decided that the way to go is to learn critical care and more specifically get interested in mechanical ventilation. So in the early 80s, I traveled to the city of London and was training in intensive care medicine at the famous Charing Cross hospitals. This was how the ICUs looked at that time. Again, a significant amount of dedication and a small amount of equipment and a lot of science, lot of enthusiasm was the primary methodology by which a large number of patients were pulled out. I then came back to India and started the critical care unit at our hospital. And during that time, the machines which were available were significantly only the first generation of mechanical ventilators. They were giving only controlled mechanical ventilation. There was hardly any monitoring. There were very simple mechanical devices, and we had to make do with such kind of equipment in order to treat our patients on mechanical ventilation. And this was one of the first ventilators that we acquired, the Monal D from Air Liquide in France. This was their first import as well, and this was the first machine which came into Maharashtra, the state of Maharashtra, way back in 1985 to treat our patients on mechanical ventilator. And it had an externally applied PEEP valve. All this sounds now so strange, but that's the way the machines were evolving. So there was an externally applied PEEP valve, and sometimes we had to consider applying IMV valve through a valve there itself. So as the machines started getting evolved from the first generation to the second generation in the 1970s and early 80s, and this was one of the second generation kind of equipment, we started realizing that the mechanical ventilation is going to go through two routes. One route is the evolution of the machinery and the equipment, and the other route is to make sure that clinical understanding of issues related to mechanical ventilation had to gather pace and be on par with the evolution in the mechanical ventilation machine industry. During that time, this was also one of the very favorite equipment, the Servo 900C, which gave similar kind of facilities as many other ventilators, and this was the prototype which used to ventilate a large number of patients. Over a period of time again, through the mid-80s and early 90s, we started seeing the third generation equipment, which started getting better triggering effort, microprocessor control, and widespread availability of certain basic modes of mechanical ventilation which were available. And some alarms started coming up. Our knowledge, of course, at that time in the pre-internet era was significantly limited to studying books. And this was one of the first books which we were reading, the Shapiro's book on blood gases. And over a period of time, of course, such books came out. Professor Vincent's book, Professor Vincent's edited book on the series of update in intensive care medicine, wherein Professor Slutsky and Brochard brought out this book on mechanical ventilation. But until that time, we were dependent on two books. One was Mushin's textbook of mechanical ventilators, wherein the knowledge and details of every ventilator which was available in the world was categorized. It was like a catalog of mechanical ventilator. But more significantly, the science was all encapsulated in this book by Professor Martin Tobin, The Principles and Practice of Mechanical Ventilation. So this used to be our Bible at that time. and all our difficulties had to be solved through this. So as the field of critical care medicine started growing, we realized that we need to make changes in order to make sure that the younger generation who is now coming into the field of critical care medicine needs to learn mechanical ventilation the scientific way, and not through just books or not through the way they only practice in the ICUs. And so a change needed to be brought to make sure that the teaching of the field of mechanical ventilation had to be brought in. And therefore we decided that the Indian Society of Critical Care Medicine was formed. We had 3 excellent conferences, and the 4th one, which was held in Pune, the 4th National Critical Care Congress, way back in 1998. This was the first time that we conducted the mechanical ventilation workshop in Pune. Of course, in the 2nd and 3rd national conferences, the mechanical ventilation workshop did take place at Chennai and at Bombay Hospital in Mumbai. However, the first one at Pune took place in 1998 during this 4th national conference. So you can see Professor Martin Tobin and Professor Jalwe Vasa looking as young as today, sharing the success of the conference and the fact that we started having the mechanical ventilation workshop. The initial workshops, this is the photo from the first workshop in Pune. This was held at Bharati Vidyapit Medical College, and the classrooms of the medical college were used for actually teaching students the basics of mechanical ventilations. And the faculty came from all across the country, and we had participations from, basic participations from industry in the form of Siemens, who had servo ventilation coming out at that time. We started producing the workbooks. This was basically a manual effort done by some colleagues who brought out the, who actually took out some articles from the journals, took their permissions, reprinted them, coalesced them to make sure a workbook came out. And this used to be an annual exercise to make sure that a significant amount of literature is available for trainees. The topics for discussion were basically restricted to initiation, blood gas, airway management, troubleshooting, and weaning. That's how the basic structure of a basic workshop started way back. Early in the 2000s, we got the first non-invasive ventilator coming in Pune, and once that was made available, that became a point of training people on the correct use of non-invasive ventilation. And over the next 10 years or so, the 10th annual workshop took place in Pune. You can see Dr. Dikshit trying to fit a mask on me as a volunteer to make sure that the demonstration of the appropriate fitting of masks on non-invasive ventilation happened. And of course, we discussed a lot of issues. Along with that, we had a congress on mechanical ventilation at that time, and we were honored to have the presence of the luminous international faculty like Professor Martin Tobin and Jajax Ruby attending that conference and participating as speakers during that conference. Now that actually was the major stimulus into growing in the field of mechanical ventilation, because they brought out the concepts of newer changes which were happening in the field of mechanical ventilation. So the emphasis of mechanical ventilation, which by that time was predominantly on improving of blood gas exchange, changed significantly to avoidance of complications by the understanding of ventilator-induced lung injury. And then significantly enough from that period, the teaching of ventilator-induced lung injury and general ventilation started becoming an important part of the curriculum of this ventilation workshop. So we started introducing the concept, the various settings on the machine, the use of appropriate prone position. And this is actually, we practiced actually what Professor Ranieri alluded to in yesterday's workshop. See, the ProSeva trial, which showed positive results, came out in 2013. But before that, Professor Gattinoni had published his data on the use of prone position with significant benefits in patients who were more seriously ill and who could be put in prone position for a longer period of time. And interactions with him during the congresses led us to understand that this is something which we must try out, despite no appropriate, adequate, positive evidence in a randomized controlled trial. So a small group of people across the country, Professor Ram Raj Gopalan, G.K. Divetia, Praveen Amin, Farad Kapadia, myself, we started trying out prone position in our seriously ill patients on mechanical ventilation. Some of these patients came out, and that was quite soul satisfying. Over the years, the fourth generation of mechanical ventilators started coming in. There was a dramatic increase in the number of ventilators available in the market at all levels. They incorporated various modes, the newer modes. The non-invasive ventilation started getting incorporated in the ICU ventilators. Most importantly, the graphics display as a part of normal ICU ventilators led us to understand the concepts of various modes, the utility, and brought out the actual mechanics of the patient very well, making sure that we understood those modes, understood the pathophysiology of that patient at that point of time, and the alterations that we had to make in these patients. The innovations in mechanical ventilation then seen thus over a period of time made us understand that we need to make sure that this ventilation workshop needs to be upgraded, and therefore from the time 2013 when we started Best of Brussels Congress, we've been having an annual workshop attached to the Best of Brussels, and this has gone off and has become hugely successful. The understanding of our mechanical ventilation needs were addressed to by a galaxy of international faculty who have graced these occasions over a period of time. We had Professor Martin Tobin, Professor John Marini, Alan Marquardt, Jean-Jacques Ruby, Laurent Brochard, Evan Gallagher, and a huge number of Italians. I don't know why Italy is such a focal center of mechanical ventilation. Perhaps Marco will allude to that. So, Luciano Gattinoni, Marco Ranieri, Antonelli, Pesenti, Cimelo, and of course Paolo Pelosi. And I take this opportunity to pay my homage to Professor Paolo Pelosi, who was a faculty with us, but unfortunately we lost him this year. The 20th workshop, which happened 5 years ago, was also associated with a diploma in mechanical ventilation, courtesy the efforts of the University of Toronto through Laurent Brochard and his group. And that was also an extremely successful event. So over these 25 years, what had changed significantly, not in just mechanical ventilation, but in the field of critical care, has seen the drivers of these development and changes have been threefold. The technology, of course, has been the main guide in changing, but the economic and social changes have also driven these development and changes in the perspective both of the patients of critical care and in the field of mechanical ventilation, in which it got reflected. Of course, a significant influence came a couple of years ago when COVID struck us. For a year, we couldn't hold the mechanical ventilation workshop. We were all busy trying to save lives. We all worked hard during that era, but the most soul-satisfying thing came from the knowledge that in these last 25 years, we have trained about 3,000 to 3,500 colleagues in the field of mechanical ventilation. They're spread all across the country, and these people were instrumental in saving lives during this COVID pandemic. So this was a very soul-satisfying information, and this was one of the biggest achievement. I think the most significant achievement of this workshop has been this saving of lives in the COVID. Of course, through the reasons which were because of the constraints of availability of equipment, a large number of our patients, despite very low PF ratios, had to be ventilated on non-invasive ventilation, and some of them did come out. So when such information started getting circulated, we decided that we will have a retrospective analysis of all our patients who were on non-invasive ventilation, and this study came out, Picasso study came out last year in the Indian Journal of Critical Care Medicine. So fortunately, despite two severe waves of COVID-related respiratory complications, we could sit down in between and make this analysis and publish it in the Indian Journal of Critical Care Medicine. Despite the satisfaction of having done something which has saved lives, I'm still appalled by some difficulties in the field of critical care over the last 25 years. I'm worried about the varying standards of critical care delivery and practice throughout the country. It is quite well understood that the resources will be limited, and critical care is a field which is resource driven. And since 80% of the healthcare delivery in India is a private healthcare delivery and only 20% is through the government, and a significant portion of the critical care is delivered in the private healthcare alone, and therefore economics plays a very major role in this delivery. The areas which are rural or which are predominantly served by the government agencies still have extremely low resources and extremely different standards of the delivery of critical care, and that's one of the more major difficulties that we face in today's world. When we try and think about this, we wondered whether the current drive for mechanization and industrialization of the country has contributed to that. Perhaps we have produced too early the growth of the mechanical ventilators as an industry and the growth of the field of critical care haven't so far matched their speeds. So we have more number of available resources in the form of machines and equipment, and lesser number of consultants who can understand what is going on in the field of intensive care to deliver with the help of these machines. And one wonders sometimes whether the industry has come in a bit too fast for comfort. When I was visiting a theatre some other day, there was an advertisement outside the theatre calling for theatre actors. And one of the requirements that they said was that we would want dedication, punctuality, commitment and professionalism is expected. That's what the advertisement said. And I wonder whether any of our medical advertisements for consultants or residents in critical care carry such kind of explicitly worded needs that if you want to be a critical care consultant, we would like these qualities in you to come in. So today we are seeing a generation of critical care people who are thronging critical care and are being trained in a very mechanical way. And at least in India, we are finding that the medical colleges are producing consultants at a very rapid pace with standards which are not necessarily matching, and therefore more mechanistic way in which such doctors are being manufactured. And unfortunately, in the absence of delivery of thinking processes, such people throng the intensive care units in a very mechanical way. And therefore, we do see the fact that protocols and lookup data are becoming more rampant rather than the thinking prowesses of these consultants. And this is what someone like me, who has seen the growth and who has seen all the international stalwarts come and teach us the field of critical care medicine and use the knowledge with wisdom. Unfortunately, this hurts us when we see that young generation coming up only with protocols and lookup data. We understand that the ICU care demands critical analytical thinking, and at some point of time, this needs to be inculcated in the junior generation. I think we need to teach them why they are in the field of critical care medicine, not just the interaction of the complex interaction between various systems, but perhaps over a period of time, I do see a significant change in the mindset of these individuals, where the predominant driver is economy and not the other interest in the field of critical care medicine. So it's about time we need to ask these people to shift their primary attention to the right things to do in life in order to save lives, because if the focus is on something else, the lives could be lost. What do we see as the future of this field of mechanical ventilation and field of critical care medicine? The mechanical ventilators obviously will go through a huge advance through the interaction of the various information, data analysis and monitoring techniques. Perhaps all modalities of ventilation possible will be incorporated in a single machine. All types of monitoring will be possible on any machine. And presentation of information will be given in an analyzed form rather than just giving data, with a support from how to make the decision. Perhaps all this will come in. The closed loop ventilation has already come in. And what these new ventilators will ensure is perhaps safety, lung protection, diaphragmatic protection, appropriate interaction by understanding the synchrony, smart monitoring and its analysis by compiling this data, and through the automation, decision making as well could be possibly advised. And all this has started because of the initiation of the artificial intelligence in mechanical ventilation. Last year itself, in the British Journal of Anesthesia, this study got published, which analyzed all the papers which have been published in relation to the use of AI in mechanical ventilation industry. And this was an systematic review of the design reporting standards and bias. And look at the number of studies related to the use of AI in mechanical ventilation over the last 20 years, how much they have proliferated. So AI will come in big way in its application to mechanical ventilation. However, as of now, if you analyze the studies associated with AI, it is said that they have this study in British Journal of Anesthesia said that it has limited external validation, limited model calibration, substantial risk of bias, significant gaps in reporting, and poor code and data availability. So as of now, we need to understand how this big data will be analyzed, and the analytical standards need to be probably more appropriate, more cohesive, and probably more analytic and more analyzed in its and used as appropriate tools. The algorithms will automatically come in from the analysis, and the future development will obviously need to be prospectively and externally validated. Unless that comes in, the use of AI cannot be considered as an appropriate step. And based on these information, we will be personalizing the ventilation. And I think that will be the biggest step in the field of mechanical ventilation, that sooner or later we are going to have personalization of ventilation, both by way of making sure that we understand the phenotype, the physiological responses of that patient at that time, the mechanical properties of that person's lungs at that point of time, its recruitability, and getting all this data to give us quick algorithms to decide on correct strategy. So perhaps the human mind will be used lesser and lesser, and such algorithms will drive our practices. For us in the past generation, it is hard to consider this information replacing our ideas on mechanical ventilation, and hopefully at some point of time the human intelligence will interact with the artificial intelligence and make sure that the decisions regarding the appropriate use of mechanical ventilation will continue to evolve. So as of today, what do we do both in Pune and all across the country? I think we need to prioritize. We need to make sure that we understand our priorities correctly in order to make sure that this mechanization goes hand in hand with our appropriate use of this mechanization. Let's not just become slaves of this mechanization. I'll allude to a note which Martin Tobin had written to me in the year 2006 when he had come here. And he had written to Shirish, "Thank you for inviting me to Pune, but more importantly, thank you for being a linchpin in accelerating the transfer of knowledge from the lecturer's mind to the bedside delivery of care to patients." Now, I think that this is the biggest message that we all in Pune and in the country need to learn. That we in India are not the original discoverers of anything. We are not likely to produce studies of the highest caliber in relation to an evolving field like mechanical ventilator, where the technology is going to be so progressively going to dominate this field. So we are unlikely to come out with anything which is original. So whatever the Western world comes out with, it is our responsibility and job to make sure that we understand it and we transfer it appropriately to the delegates, like the delegates coming to the mechanical ventilation workshop, and make sure that that gets transferred at the bedside to save lives. And I think this is the most singularly important purpose of continuing with such activities like the mechanical ventilation workshop. So the future of these kind of workshops is very sound, because we need to pass on this wisdom of appropriate knowledge coming from the Western world and coming from the academic world to the fresh minds of graduates in India, and make sure that they understand it appropriately and make sure that that is applied to the delivery of the process of patient care at the bedside. The caring of the critically ill is a complex and difficult task, and we must be aware that what matters lie in the details. And we can continue to remain optimistic if we are more and more patient-centered, pragmatic rather than dogmatic, less invasive and concerned about safety. And this came out from our two colleagues in the field of mechanical ventilation. As Professor Marco Ranieri was alluding to yesterday, ICU is perhaps the best physiology lab, and all our art of understanding the physiology needs can be tested if physiologically appropriate. If physiologically appropriate, I am not saying just try out any ideas at the bedside. If not contraindicated and if physiologically appropriate, we should be trying it out. Otherwise, we would not have understood the concept of dynamic hyperinflation, which came out in the late 80s through succinct observations which were done at the bedside to see why a patient of bronchial asthma on mechanical ventilator was going repeatedly into cardiac arrest and was getting revived when disconnected from the mechanical ventilation. That brought out the clinicians to understand what is the concept of dynamic hyperinflation. And prone position is a class example. If Professor Gattinoni had not continued to try it in various ways despite negative RCTs, we would not have had such a major contribution to the field of mechanical ventilation. And today, so many people in the world are alive because they were put in prone position during the COVID pandemic. So the physiologically sound ideas need to be appropriately tried at the bedside. And we shouldn't be taking everything only by the evidence-based medicine, as Professor Marco was alluding to, and Professor Vincent so eloquently showed this morning, that it's not just the RCTs. Obviously, they are the final holy grail of confirming any scientific advance. However, not everything needs to be understood. We need to understand the physiology. We need to make sure that we think and apply this at the bedside. So the future of intensive care and the intensivists, ladies and gentlemen, will depend basically on how the intensivists are going to think about the patient at the bedside, its pathophysiology, of what our therapy or the mechanical devices are going to do, and make sure that that is applied appropriately. And I'm going to sign off with a wonderful song. No, don't worry, I'm not going to sing it. This song is this is a Latin song, and it means, please forgive my pronunciation of the term, it might be inaccurate. Gaudiamus igitua, that's the pronunciation of word. This is a song which says, therefore let us rejoice. This is supposed to be a Latin song which was scripted in the 12th century, and it's a popular academic song which is supposed to be sung in many European countries, mainly during university graduation ceremonies. The song tells us to rejoice life and make sure that we come out and do the right things in life. The most important concept of this song is that John Stone in JAMA published a poem which was its translation, which was a loose translation of this song done in English. And he wrote this 40 years ago, and this year is the 40th year of anniversary of this song written in English. And he wrote this version of the original poem as a graduation address for the newly minted physicians at the Emory School of Medicine in 1982. And it continues to be a traditional commencement song that celebrates the promise of youth and reminds graduates that life is fleeting and we need to make sure that we do the right things and still at the end rejoice the fact that there is life. And a stanza of that poem written by John Stone in JAMA resonates so much with the field of critical care and especially with the field of mechanical ventilation that I was tempted to quote it for you. It says that for you will be invincible and vulnerable in the same breath. You will be invincible and vulnerable in the same breath, which is the breath of your patients, for their breath is our breathing and our reason. And I think it's very appropriate that we all, as critical care consultants, remember this. Their breath is our breathing and our reason. And therefore, let us rejoice at this thought. Thank you very much, ladies and gentlemen.
I request Dr. Danish to come up on stage. Thank you, Dr. Prayag, for such an excellent talk.
I request Dr. Kapil Zilpe, Dr. Samir Zog, and Dr. Subal Dixit to please come on the stage. Good afternoon, ladies and gentlemen, and after that wonderful, overwhelming talk, it is my proud privilege to tell you a little bit more about Dr. Shirish Prayag, a mentor, teacher, and friend to many of us here today. Dr. Shirish Prayag is the Chief Consultant in Internal Medicine and Intensive Care at the Sri Medical Foundation, Pune, and is one of the pioneers of critical care in India and Southeast Asia. His dedication as an intensivist, caring for the very sick patients, his love for teaching critical care medicine to many of the intensivists of India today, and the relentless service in the field of critical care medicine for the last 40 years has made him a renowned figure around the world. His contribution to the development of critical care medicine as a new medical specialty in India and Southeast Asia is undoubtedly appreciated by intensivists all over the world. He completed his MBBS in 1974 and MD with a gold medal in 1978 from the prestigious BJ Medical College, Pune. A brilliant student throughout his career, he won a number of awards and medals, including the Best Outgoing Postgraduate Student. Aspiring to excel in the field of critical care, which was in its infancy back then in India, he went to the Charing Cross Hospitals, London, UK in 1982 and was one of the very few Indians training in the field of critical care medicine at that time. He returned to India with vision to treat the critically ill patients. He started the first critical care unit in the city of Pune in 1986 and developed a team of dedicated staff for his ICU. He is still in charge of the same unit till date and has treated over 25,000 critically ill patients in Pune. One of the pioneers of critical care in India and Southeast Asia, he has been responsible for setting up the scientific and academic platforms for this field in India. He is one of the founder executive committee members of the Indian Society of Critical Care Medicine in 1993. He performed many roles right from its inception till now. He was the president of the ISCCM from 2000 to 2002. This has now gone on to become a large body of 17,000 members with more than 50 city branches and 28 annual national congresses in which he has always been invited as faculty. Through the society, he developed the first training program in critical care in India at the national level, devising curriculum, inspecting and approving centers and teachers for training, and conducting the first few national examinations. He started the annual mechanical ventilation, which we all enjoyed over the last 2 days, the first of its kind, and it has been held every year for the last 25 years, the Silver Jubilee, of which we celebrated over the last 2 days at the workshop yesterday. He was instrumental in establishing the Critical Care Society of Sri Lanka and was the first honorary member of the Sri Lankan Critical Care Society in 2009. He has developed this novel encapsulated program of reproducing the talks given at the annual ISICEM Brussels in Pune, India for the Indian audience, so that we do not have to spend so much of money to go there, and we can enjoy the knowledge, the transfer of knowledge, and practice it at our bedside. An excellent clinician, inspirational teacher, and father figure in critical care, he has sowed the seeds of this science which has grown and spread its branches all over India and Southeast Asia. He was elected to the Council of World Federation of Intensive Care Societies and hence instrumental in putting India on the world map of critical care and stimulating India's participation in international trials like the EPIC-2. He was the first Indian to be elected to the Executive Council of the World Federation of Societies for Intensive and Critical Care Medicine 2001 to 2009. He was unanimously elected to the Council for Patient Safety in Acute Care, an international committee which has the World Health Organization's support. He was awarded the honorary degree of Fellow of American College of Critical Care Medicine by the Society in 2000 and was the first consultant from India to get the fellowship. His contribution, no doubt, to the growth of critical care medicine in India and Asia is truly commendable. He is the golden thread which strings us together to work as a team and strive to be better doctors, teachers, and human beings. We thank you, sir, for delivering the commemoration lecture to celebrate the Silver Jubilee of the Mechanical Ventilation Workshop, which you started 25 years ago, and we hope that we can celebrate the 50th Golden Jubilee with you in the years to come. I now request all the members on the dais to felicitate Sir for his commendable work and his life's dream.